We're at the 2019 CROI, and we're here in Seattle with Daniel Fierer, who's from Mount Sinai Hospital in New York City, and just got out of a press conference that included his press information about the presentation he made. And I think it'd be good to let you recount a little bit about what you talked to us about in the press conference, and we'll have a little conversation after that.
Yeah, great. So what the study that I presented today is about, it's really the culmination in some ways of over a decade of our trying to understand sexual transmission among men. And in this case, men who have sex with men, our initial focus is on men, HIV-infected men who have sex with men. So it was really back in 2006 that we first got the sense of sexual transmission, and that was something that hepatitis C is not supposed to be a party to. And so to try to figure out what was going on, in addition to some other things that we had observed, I went into the community and to other docs around and asked the providers of HIV care, a lot of physicians assistants, nurse practitioners in New York, a lot in private practice, non-academic sites, for their cooperation to try to figure out what was going on. There were a few practices had seen a few, but I hypothesized that by putting together this, we'd have the many practices in New York, we'd have a really powerful way of looking at it. Because of our decentralized healthcare, it's not quite the same as the Europeans' ability to pull people in. And this almost grassroots recruitment, very different than the usual academic setting, where it's people that come into your tertiary referral center, I think was very effective, and I'm very proud of that. So this is the New York Acute Hepatitis C Surveillance Network. And so we have learned rather a number of things about sexual transmission in these years, and we could talk about that at some other time, but what this is really a long-term follow-up and enabled us to do, I think, some very powerful things with this. So what this particular project was is to look at the reinfection rate after treatment, curative treatment, or clearance of the primary hepatitis C infection. And so it had hundreds of men referred originally, and many were treated and cured, and some cleared. We were able to follow 304 men who had a cleared hepatitis C infection. These are all HIV-infected men who have sex with men. And some were cured in the older days of interferon treatment. Somewhat more now actually had been cured with the new direct-acting antivirals, and some spontaneously cleared. And we followed them to see how many and what proportion became reinfected. And broadly what we found was that a total of 12% of these 305, 38 became reinfected once, and 6 of those became reinfected subsequently. So the total, with the years of follow-up, we call it person years, so it's 845 person years. That's a pretty substantial number of years average follow. Over 2 years average per person, we found that the rate of reinfection was 4.4 per 100 person years. Now, what does that mean in perspective at all? Well, the primary infection incidence rate, so first hepatitis C infection among HIV-infected MSM in New York City. The New York City Department of Health did this very interesting study where they were able to look at all 41,000 plus HIV-infected MSM in the first decade of this 21st century, and found that the reinfection rate was 0.6 per 100 person years, less than 1%, if you want to think of it that way. So what we found is over 7 times higher rate of infection from reinfection. And so what's important about this is that I think there's been a general sense, especially in context compared to, say, people who inject drugs, heroin addiction, people who are tend to be sharing blood products, the infection rate is much higher in this group. And so it was viewed that it's like, oh, the incidence rates of less than 1%, that's really very little, it's inefficient, and sexual transmission, heterosexuals really don't transmit much at all, so this is a low efficiency, and we see this, but it's not so common. It turns out this has been documented in countries across 4 continents in both hemispheres. This is from North America, Europe, Japan, Taiwan, Australia. So this has been very well documented across the world, every place that's looked. But the rates may be relatively low, and so maybe it's not, depending on your perspective, how important the problem is. And so this rate of reinfection is really quite high. And what I find striking is that we were not the first to describe this. European groups, especially with their healthcare structure and the way they've been much more interested in this particular problem, I think, than overall those in the States. And so they have found very similar things where the reinfection rate is 5 to 15 times higher than the primary infection rate. And what that means to me, I think it is not maybe has been discussed so much in the field. I think that what's important about that is that, and it seems so obvious once you say it, that all HIV-infected MSM are not at some uniform risk of getting hepatitis C, and that it's much more likely that the risk is in a smaller subgroup, and that in this subgroup, though, the risk of infection is actually quite substantial. So if we rethink it and think, oh, well, it's sort of a low risk spread out, well, that doesn't make much sense. And this is a common problem we have with statistics in general, average. Well, it tells you very little about individual things. And unfortunately, though, that hasn't, by thinking of it that diffusely, we haven't really concentrated as much as we should on who the people really are, who are really at risk. And so this is sort of the beginning of that. So I put the simplest thing in thinking about that as well. Anyone who's had a first infection is by definition at higher risk.
Right.
And so then a proportion of those would be reinfected. So if we start there. But that's not enough either, because what happens, we treat people and they're cured, but then they go back to a what we call like social network, social sexual network, and become reinfected. So it's, well, okay, in a time when treatment was difficult and cure of HIV-infected men from hepatitis C with interferon with genotype 1, which was a predominant genotype, is down to the 20-25% level. That's a year of treatment. So, of course, we didn't get many people treated. But since 2014, we supposedly have lots of people get treated. Well, of course, restrictions on use of these new drugs and access to care has been very difficult, makes it hard to do. So one of the analysis we did was we looked at the time period from 2013 back, the interferon era, and we looked at 2014 onward. We had technically availability of sofosbuvir in December 2013 when it was released. So did we see a difference in reinfection? No, they were statistically the same in these two eras. So that tells us that we were not really doing enough of a job of treating. Think about the community a lot. I think about this a lot the way we think about HIV prevention, and so the community viral load, for lack of a better word, was still very high, even in this period of time. And this is reasonably up-to-date data. We got follow-up data on those people through 2018 to some point. You know, in the study, you have to sort of draw your line in where you're going to gather data and when you're going to stop. I wanted to keep going, but we had to stop to do a data analysis. So. That tells us we haven't really treated well despite the rollout. So our people who are at somewhat higher risk are going back to a social sexual network and getting reinfected. And so, but it also says, well, we think we know there because these are the people who got primary infection, but we're obviously missing a fair group. We don't really know who they are. We think in our HIV clinics, actually we've done a pretty good job. So we believe that most people who will come have been treated, and I talked to all the practices who referred me and said, well, is there anybody left I can treat? You can send them to me if you don't, if it's too hard to get prior approval and you don't have the administrative stuff, I'll do that. That's what I've been dedicated to do. Provide this as a service so we can help study it. Right. And pretty much everyone says, well, we've really treated everybody who comes in. And so we're missing, it's sort of a silent unknown group. So this is a real, one of the real disparities in care that we don't even know where the disparity is exactly. We can hypothesize. For instance, we got one signal in our study that Latinos were a little, it was a borderline statistically significant finding. Latinos were more likely to be reinfected than non-Latinos. We did not find that blacks compared to whites, even though for primary hepatitis C infection, the New York City Department of Health found that the primary infection rate was higher in Latinos. So this made sense that reinfection
Was it relative to the general population in that ethnic group?
Latinos compared to non-Latinos generally, and that's the primary infection was also higher in blacks than in whites. Again, healthcare disparities that are very well known in the U.S. We didn't see that in reinfection among blacks, but we did in Latinos. And so there are clear, well-known healthcare disparities. I don't know personally how to get at that because I treat everybody the same, and I think that the people who, the docs who take care of them treat them the same. So it suggests that maybe the prevalence in the community in which they're having sex has a higher prevalence. If the prevalence is very high, even very good prevention methods make it very hard, as we see for HIV acquisition in black MSM in the South. Prevalence is so high that even with better condom use in that population, there's still a high transmission rate. So
it's relative to the number of sex acts one individual has, or could it also be the type of sex act that they're having?
Yes, but I want to, before you finish with that statement, it's a combination of the prevalence in the community, right? If there's none, you can do all the transmitting behaviors possible. If there's no Hep C, you'll never get it, right? And similarly, if the prevalence is very high, if 90% of the people you come in contact with, even very low risk kind of behaviors could result in transmission. So those two factors are really key. So the type of sex, we did a case-controlled questionnaire-based study originally we published in 2011 with the CDC, and looking at men who did not inject, people who got their primary hepatitis C, these are HIV-infected men who have sex with men, and actually set aside and analyze just those who said they didn't inject any drugs, so that we can look specifically at sexual transmission. And the two very highly statistically significant risks were bottom no condom receiving semen into the rectum, and being high on meth at the time, specifically meth and not G, K, X, any of the alphabet soup. And it was a striking finding of sexualized drug use.
Is it the disinhibition with the, or was it the drug itself?
It's a good question. Is there something about the biology itself of methamphetamine? I suspect it's not. I suspect it's more behavioral, although teasing that out is not something that I have done, but I think that it brings you to a situation.
Does it drop your immune system, or?
I don't think so, but we don't. But it's an idea. I think there are different drugs were used as sexualized drug use in different cities. In New York, the meth use is goes way back in the gay community, and so it's also associated more with HIV acquisition. I think there's something a little bit special about meth in terms of disinhibition and euphoria compared to, say, even cocaine or alcohol. Certainly people have been getting drunk and having sex and having all sorts of things happen, from pregnancy, all kinds of sexually transmitted things for quite a long time. It doesn't have to be meth, but I think there may be something. In New York, it was a very clear signal that was the case. And so I suspect that is also very much important in reinfection as well. There are other factors and other risk factors about possibly sharing straws. We have some risk factor things to do that I haven't completed yet.
So will you yourself engage in further activity in this regard, or will you, see others help and maybe gain some partners around the country who can look at it in their high prevalence areas?
Yes, I have been trying to encourage other researchers in the U.S. to be involved in this. I have some collaborations on and off with the San Francisco folks. It seems a natural collaboration. We recently published about MSM taking PrEP, getting hepatitis C, for instance, in collaboration with San Francisco. We had that out this year. We didn't look at that in this. This was specifically HIV-infected MSM.
Anything that's behavioral, an action that you can stop or know that you could stop would be helpful.
You can stop sex, So this is a tall order in this age.
It's just that if you know, at least if a person knows, and we know what's actually causing this specifically, or a sex act, or maybe it's just a number of acts that you do in a month. I mean, there's a very different. Some people are just proliferate with sexual activity.
Yeah.
Others are, just like once on a weekend, and
Right.
others go to bathhouses. So there's a lot of, very different activity there.
Yeah. Well, I think it's important. The ability to enjoy one's sexuality is something that I heartily endorse, and so I think that it's a very tough balance. So my approach has been to provide information to my patients about what we found. We had found that there's hepatitis C and semen. We followed up. Well, if the main risk is getting semen in rectum after intercourse, well, let's look in semen, and we and others have done that and found that. So I tell my patients, well, the men who came before you in my study. Well, I don't even necessarily say that. I said, well, the men who came before you in this study, some donated semen specimens. We found that a third of men, a third to half, the Australian group found half, had Hep C in the semen. Though logically, a condom would prevent that getting into your rectum. But I don't even feel that. I feel like providing the information is important. I said that also in rectal fluid, half the men have rectal fluid, so maybe it could infect your penis, but if you're the second bottom in group sex or fist or toys, you could have hepatitis C coating that and then brought into your rectum. I feel like providing that information rather than just, people can make their own logical leaps about how that went. It is important though to mention that condoms could do it, because people might wonder, well, maybe hepatitis C isn't prevented, gets through a condom. So I think that's important, and the answer is no, it wouldn't. It would be like HIV, and it would not get through the condom. And
the more information you have in your questionnaire, or however you're doing your survey or study, is important, because I think a lot of people really want to know. Some don't care, but having the information is a valiant effort, and certainly responsible on your part to do.
Yeah, I want to bring that. Can I make one other, I think it's an important point about a concern about how bringing out this kind of information can be stigmatizing, and because of saying, pointing a finger or saying, wow, look at how high this infection risk is, this is bad or bad people. So first of all, I absolutely categorically reject that idea. First thing is, our greater goal in medicine, I take care of people, and so I treat people, and we treat everybody's infection.
Treat them where they're at.
Yeah, no matter what it is. And we don't deny, hepatitis C is particularly stigmatized. We don't tell people who, for instance, have coronary artery disease and may continue to go to McDonald's, and we may say, well, the doctor said, you got to stop going to McDonald's eating that, but if you need another coronary stent, you don't say, oh, I'm sorry, Mr. Smith, you keep eating McDonald's, we're not giving you that stent. That's
it's judgmental.
Crazy. It's right, and yet somehow we do that with hepatitis C, but I want to discourage that. The second thing is about the importance of finding reinfection is actually a necessary phenomenon in treating people who are actively transmitting. This is showing success in finding the target population to eliminate it. You will have to have reinfections. This is true in injection drug use, whatever the risks are. And so this is actually good, and we can identify people and maybe discuss it and figure out ways with them to comfortably within their lives change that behavior. We still need to learn how to do that.
Right.
But
I mean,
this
having the answers for people that want the answers to the questions is critical. If people don't want to change their ways or their habits or their sexual performance, then so be it. You have to kind of like, we had a lot of these conversations over the years. It's ethical and behavioral. It's just what it is. The same thing we do with needle sharing and so forth. It's another big issue. You try to work with people, but it's important for you to learn this, and I hope that you can find collaborators in other cities and maybe in other, Australia or who knows where.
The Europeans have been very close, and the Australians, and we do have a good collaboration. I sit in the meeting with those folks, and we have a great time talking to each other and sharing these different things. And I can share a little tidbit that what I learned just in the week before the presentation, that the National Health Service in England, they were what I think many of us medically would say very slow to be willing to allow the use of DAAs as part of the NHS. It was only in 2015. They had an enormous reinfection rate there, 15% as a result of that as recently as 2015. But while they have now said, okay, you can could treat people. They're saying you can't treat people in the first 6 months of their infection. This is arguably the period where people are the most likely to continue to transmit, and they're not allowing retreatments. And so I helped supply them with my experience. They said, well, what can we bring to the English government? I said, well, 9 of the men I treated were cured with a direct-acting antiviral and got reinfected, and I cured them. And of course it works, but a quarter of the group, that was the case, and I hope that the experience we have in New York can help the docs and scientists in the arguing with the NHS, saying we have to get these drugs. So this is an international collaboration for sure.
And I think whenever you have a study or a survey or whatever it is that's going down, it would be helpful to always include the community and the input, so you have that and that buy-in. And I think it's that way you feel a little more confident in that there is, and if you bring the target population into it, it's always important.
I believe that I learned from my patients. I got a real crash course coming in about drug use. They told me websites, go get these publications, and I was pretty expert at heroin and us infectious diseases people. We learn. You have to learn a lot about different drug use, and I learned a lot. And they helped design the questionnaire that we used initially, and certain patients that come in and meet with them about various things in our questionnaire design. So yes,
because it's important to have that perspective, and also. I really feel strongly about doctors who are performing and getting into research have at least an ear to the clinical side, because it's not always the case, and especially in the part of it where you're handling in behavioral and so forth, it's a challenge.
Yeah. So, it's been a real honor for me to take care of these men and to be able to provide medical care, and to then basically enlist all of them. I tell everybody that each person has an opportunity to help those who come after by participating in very simple ways of maybe a blood sample, or we're generous with their semen. And we have made a lot of progress, I think, in understanding sexual transmission. We have miles to go, but this was really the generous contribution to the men who came to see me, who have reason to be concerned about stigma, and but yet really have been selfless. I haven't asked for any pieces of organs recently, but still really generous with.
As long as your heart and your energy is put in the right direction, I think everyone buys in. It's just where there seems to be this adversarial thing going on, and we don't want that. We want to make sure there's a buy-in by the community, and then it'll go. But it's really helpful. I really appreciate you taking the time to explain this whole thing to me, and we look forward to the progress on it. And let me know how the collaborations are.
Yes, wonderful.
All right, thank you. Thank you, sir.